Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Results of a Pivotal Phase 2 Study of Brentuximab Vedotin, SGN-35, for patients with relapsed or refractory Hodgkin's lymphoma, by Anis Yunus et al. My name is Robert Seufer, and I am Chief of the Division of Hematologic Malignancies at Dana-Farber Cancer Institute in Boston. My oncologic specialty areas include leukemia, lymphoma, and hematopoietic stem cell transplantation. Speaking on A New Day Dawning for Hodgkin's Lymphoma. The treatment of patients with Hodgkin lymphoma has long been hailed as one of the great successes of oncology. Chemotherapy and radiotherapy, alone and in combination, have produced long-term remissions in the majority of newly diagnosed patients with Hodgkin lymphoma. This has erroneously led to the conclusion in some lay and medical circles that we as a medical community can always cure this disease. Unfortunately, not all patients attain a remission or remain in remission after primary therapy. Salvage chemotherapy and subsequent autologous hematopoietic stem cell transplantation can cure a selected subset of patients with recurrent disease. Still, approximately 50% of autologous transplant recipients are destined to relapse. Options for patients whose disease recurs after autotransplantation are limited. Reduced intensity allogeneic transplantation can produce durable remissions in a fraction of patients, often, however, at the cost of disabling chronic graft-versus-host disease. Numerous conventional chemotherapy regimens appear to have activity and contribute to the success of Hodgkin lymphoma therapy, including components of MOP, ABVD, BIACOP, and ICE. It is worth noting that all of these agents were introduced more than 20 years ago, and most before 1980. More recently, newer combinations such as gemcitabine, vinorelbine, and pegylated liposomal doxorubicin have induced usually short-lived responses, but none of these agents has received an indication specifically for Hodgkin lymphoma. Not until brentuximab vedotin, SGN-35, has a new drug received FDA approval for the treatment of recurrent Hodgkin lymphoma. Brentuximab vedotin is an antibody-drug conjugate that delivers monomethyl auristatin, E, MMAE, an antimicrotubule agent to cells expressing CD30, an antigen commonly present on Reed-Sternberg cells. In the paper that is the subject of this podcast, Yunus and colleagues report on a multi-center trial of 102 patients treated with brentuximab vedotin for Hodgkin lymphoma that recurred following autologous transplant. This heavily pretreated population had received a median of 3.5 prior regimens in addition to the autologous transplant. Over 60% had also received radiation therapy. In this series, 75% of patients had an objective response rate, with 34% achieving complete remission. Of those that achieved CR, median duration of response was over 20 months. For the 57 patients who had received a salvage regimen after autologous transplantation, but before brentuximab, progression-free survival after the brentuximab was longer, 7.8 months, than after the salvage chemotherapy regimen, 4.1 months. Investigators administered a median of 9 cycles of therapy, range 1 to 16, at a dose of 1.8 milligrams per meter squared every 3 weeks. Toxicities included nausea, vomiting, diarrhea, and fatigue, though most were characterized as grade 2 or less. Grade 3 neutropenia was noted in 14% of patients. The most common side effect overall was peripheral neuropathy, occurring in over 50% of all patients, with 9% scored as grade 3. Peripheral neuropathy led to discontinuation in 9% of patients, administration delays in 13%, and dose reductions in 10%. Neuropathy resolved completely in 50% of patients. The results reported for brentuximab vedotin have already generated great enthusiasm among physicians and patients alike. It is the first targeted therapy developed for Hodgkin lymphoma and other malignancies expressing CD30. It has been more than a decade since rituximab, targeting CD20, was introduced for the treatment of Hodgkin lymphoma's more common cousin, B-cell non-Hodgkin lymphoma. Monoclonal antibody therapy with rituximab has revolutionized treatment of most B-cell malignancies and, in different scenarios, is utilized alone, in combination with cytotoxic chemotherapy, and as maintenance. It is tempting to predict that brentuximab will have as widespread an impact as rituximab. However, it must be remembered that brentuximab has only been fully vetted in one large trial as a single agent in patients who have relapsed after autologous stem cell transplant. Studies evaluating brentuximab alone and in combination with chemotherapy as salvage prior to transplantation, as maintenance after transplant, and as a component of initial treatment for newly diagnosed patients are either underway or being planned. We need to await the results of these trials to determine whether this agent fits in the treatment paradigm for Hodgkin's lymphoma. In addition to accumulating more information as to brentuximab's contribution to controlling Hodgkin lymphoma in different settings, we must also gather data regarding its potential toxicities. In particular, peripheral neuropathy, perhaps related to the MMAE antimicrotubule conjugate, develops in over 50% of patients, with some patients suffering significant impairment. Despite being a quote-unquote targeted therapy, this is a clinically important off-target effect. Establishing a safe dose when administered in conjunction with chemotherapeutic agents with their own risk of neurotoxicity will be a critical endpoint of the ongoing trials. In addition, developing an optimal strategy for management of patients with peripheral neuropathy is necessary to safely maximize the benefits brentuximab may provide. After decades of perhaps being a bit ignored in terms of novel drug development, Hodgkin lymphoma has drawn the attention it deserves. A new antibody-drug conjugate, brentuximab vedotin, designed specifically to target CD30-positive malignancies, has produced exciting results in heavily pretreated Hodgkin lymphoma patients in whom even autologous transplantation could not produce sustained remissions. We eagerly await ongoing and future trials which will determine how brentuximab can be optimally incorporated into other treatment settings for Hodgkin lymphoma. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.